nice to see a broad group of nurses coming to this. I must say, when we were putting this together, it was very difficult for us to jam it all in. So this is lots of information in a short amount of time. If you guys ever want us to come out to do some talks with the ward, each ward, we're more than happy to. Just let us know. So we're going to talk about two cases specifically, and just a show of hands, does everyone know what HFrEF and HFpEF is? No? Okay, all right. We'll go into that. So objectives-wise, we'll just review significance of heart failure, bit of patho, not too much into that. I think a lot of us know the basics here. Discuss clinical presentation of heart failure, signs and symptoms, triggers. Also go over diagnostics and recognizing heart failure on echo, which Sarah will be doing for us. And then go into treatments, so pharmacological treatments, therapies. And then what's really important for this series today is to go over essential to patient education. I think that's a domain that nurses can really excel at, and we are the ones who are going to, at the front line, giving this information to patients. Of course, at the end, we'll be, if we have time, we'll definitely have some opportunity to ask some questions. So just generally, just some facts. So heart failure affects approximately 1 to 2% of Canada's population. That's estimated about 550,000 new heart failure cases each year. Overall, the 5-year mortality rate for heart failure is quite high. It's 50%. 1-year mortality for those who have very severe disease symptoms, that being NYHA class 3-4, is anywhere from 11 to 44%. And really, those who have severe class 4 NYHA symptoms that are basically almost bedridden because they have overwhelming heart failure symptoms, are hospitalized, and their 1-year mortality is very high, 40 to 60%. Men versus women. Does anyone know, does heart failure affect men or women more? Equally. Yep. So we don't have any advantage as women, and men don't either. It increases with age. Women, though, when they with heart failure, tend to be a little bit on the older side, and they often have a history of high blood pressure. Men, on the other hand, with a history of heart failure, have a history of MIs, heart attacks. Okay. Heart failure, then, is gaining popularity. What do I mean by that? Well, with our advancing age of our population, we are projected to have quite a number of heart failure patients. And you probably, especially in eMERGE and on the ward, you'll see patients that have had we know that 75% of patients that come in with heart failure already have that diagnosis from the past, and they're coming in being readmitted with their heart failure symptoms. Bottom line, incidence of heart failure is very common, regardless of sex, and increasing in incidence as we go along. Heart failure admissions. So you can see here, day 30, it's about 8.7%, up to 1 year, up to a quarter of patients with heart failure are readmitted back into hospital. Did you know that heart failure is actually the most expensive healthcare expenditure? And average stay for heart failure patients is about 6 days. The more frequent admission of heart failures, the higher incidence of mortality. Okay? So each time they come back, they have a higher incidence of dying. So I'll just pass the mic along to Diane, who will go into pathophysiology.
So hello, everyone. So we'll just talk about I don't want to drop this. Just hang on to this. So basically, what is heart failure? So this is one of the definitions. There's a few. I particularly like this one because it's fairly simplified. It's basically the inability of the heart to pump blood at a sufficient rate to meet the metabolic or tissue demands of the body, or it can only do so from an elevated filling pressure. So heart failure and ejection fraction. So who's heard of ejection fraction? I know the CCU nurses would have. Are there medicine nurses here? Yeah, so ejection fraction is basically the amount of blood that is pumped out with each heartbeat. So basically like 2 to 3 ounces of blood with each heartbeat. A normal ejection fraction, or EF, is about 55 to 65%. And so we're going to talk about heart failure with a reduced ejection fraction, or HFrEF, which often most of us probably know that as systolic dysfunction. And also the other type of heart failure has a preserved ejection fraction, or EF of greater than 40%, what we call HFpEF. So heart failure with preserved EF, or preserved ejection fraction, or you may know this as diastolic dysfunction. So Erin and I are going to talk about 2 cases today, Mr. R and Mrs. P. So Mr. R has a reduced ejection fraction. We'll talk about some of the pathophysiology, some risk factors, diagnosis tests, medications that are used. And Mrs. P, with preserved ejection fraction, we'll talk a little bit about the patho that goes with that, risk factors, medications, and some self-care. So what are the most common causes of heart failure? So the CCU nurses, you probably see this all the time, right? Coronary artery disease. And again, that goes with our men having MIs. And the second most common cause of heart failure is hypertension. And again, like Erin had already mentioned, that often we see this with the elderly women coming in with hypertension. Heart failure can also be caused by valvular disease. So either regurgent vessels, valves, or stenotic valves. They can be caused by arrhythmias, like a fast AFib or A-flutter that's not controlled, or a sinus tach that goes on for quite some time, making the heart work hard. Okay. How's that?
That's not a microphone, Diane.
Oh, it's not?
It's a recording mic.
It's just a recording mic.
Okay.
So you can say it, talk about it.
Oh, okay, I don't. Here, I'll talk into this. Toxins like alcohol use and certain drugs like meth and cocaine can actually damage the heart muscle and lead to heart failure. Chemotherapy, some anthracyclines can actually, or radiation to the chest. So we have a lot of women coming through our clinic who actually have been treated with anthracyclines for, say, breast cancer or certain, cancers years ago, maybe even 10 years ago, and now they're presenting with actually heart failure. We also know that radiation to the chest, like the breast area for breast cancer or lung cancer radiation, can actually cause some sclerosis to the coronary arteries, which can lead to heart failure symptoms as well. We know that certain viruses can actually affect the heart muscle and damage the heart muscle, leading to heart failure. And then there's also familial or genetic causes that can lead to heart failure. There's quite a few other things like hemochromatosis and others, but these are the most common that we actually see. So who loves and knows the patho of the renin and angiotensin and aldosterone system? 2 minutes, so let's go. All right, so if you have something like heart failure, it decreases your coronary output, right? So usually you get decreased perfusion pressure through the baroreceptors that are located in your, aortic arch and your carotid arteries. So the decreased perfusion pressure causes some decrease in your renal perfusion, which then sets off this cascade, or this neurohormonal cascade of kind of up-titrating. And it's a compensatory mechanism for when you have low blood pressure and low cardiac output. So you get renin decrease being secreted, which acts on your angiotensinogen, which forms into angiotensin 1. Then you get your angiotensin converting enzyme that acts on your angiotensin 1 to form angiotensin 2, which is a potent vasoconstrictor. So in the short term, vasoconstriction is good because what is it going to do? It's going to increase your blood pressure, right? But over long periods of time and chronically, you don't want high blood pressure. So your angiotensin 2 stimulates your CNS system. So you get increased heart rate, increased cardiac contractility, increased blood pressure. It also gets this aldosterone secretion going, which then increases your water and sodium reabsorption in your kidneys. So then you're getting increased intravascular volume and fluid retention. Again, like I said, increased arterial vasoconstriction, increased blood pressure. And then you also get the pituitary gland decreasing or secreting, your ADH, your antidiuretic hormone, which again then causes water reabsorption. So all of these together, short term is okay for compensatory mechanism, but long term, not good. Alrighty, so why do we care about this? Well, Bonnie, our pharmacist, is going to talk about some of the drugs that we use to block some of these pathways to then prevent worsening and worsening heart failure. So, clear as mud? Alrighty, so some of you have heard of the New York Heart Association classes, class 1 to 4. We use this to basically classify our heart failure patients, basically how they are functioning and what their symptoms are like at that moment in time. Because as you know, heart failure tends to change over time. Sometimes people can be very stable for a long period, and then they have these exacerbations where they get worse and end up in hospital, then they get stabilized, they feel better, they go home, they're stable for a while, then they end up back in hospital. So we classify them. So class 1 is basically no symptoms, really no physical limitations compared to a normal person. Class 4 is severe heart failure symptoms. So like Erin was saying, that symptoms at rest, maybe bedridden, very symptomatic, short of breath, without doing much at all. And then class 2 and 3 are kind of in between that. Mild symptoms, occasional, limited ability to do exercise. Oopsie. Limited ability to do strenuous exercise, like some people might say, well, I can walk a block, but if I make my bed, I get really short of breath. Class 3 is kind of moderate symptoms of heart failure and not able to do as much, comfortable at rest though. So we use this because every time people come into our clinic, we want to know kind of where are you at that moment in time. Because we know that the worse your heart failure is, the worse mortality. So heart failure symptoms, there's quite a few, but the kind of classic heart failure symptoms that we see in patients are your classic shortness of breath, fatigue, and edema. There's quite a few other things like shortness of breath at rest when you lay down, PND, paroxysmal nocturnal dyspnea, waking up in the middle of the night, feeling short of breath, where you may go to bed fine, but you've got extra kind of fluid in your extravascular area, and then once you lay down, kind of that fluid seeps into the bloodstream, in through the lungs, and then wakes you up a few hours later, feeling short of breath. People may feel lightheaded, syncope, presyncopal, abdominal bloating. Some of the other ones you might see, weakness, confusion, especially in the elderly. That's something to watch out for. Limitations in daily activities. They find they just can't walk as much or do as much as they normally do. Chest discomfort, decreased cardiac output again, nocturia. Of course, when you lay down supine, you get more blood flow to your kidneys when you're supine. So some people find that they end up getting up during the night to pee a lot. Cool extremities. So some of the heart failure signs that you'll be assessing when you see your patients are looking for lung crackles or listening to lung crackles, your elevated jugular venous pressure, your positive hepatojugular reflux. When you press on your abdomen and, does the blood go up your JVP? So our lungs and our bellies can hold, and our livers can hold a lot of extra fluid. So sometimes you might not see it, but you start looking for it and you can find it sometimes. Displaced apex, so again, if you've got an enlarging heart, sometimes the apex is going more lateral over into towards your armpit. S3 and S4, so again, can indicate heart failure or a stiff heart, low blood pressure, and a high heart rate, because the body's trying to compensate, right? So we're going to talk about Mr. R, this poor man. So he's 65 years old. He's a real estate agent. He has a history of hypertension. He's an ex-smoker. He has high dyslipidemia. He's sedentary, doesn't do too much. He's driving around his car, doing business. He has a poor diet because he eats out a lot. He has increasing fatigue. He's winded with stairs. He has chest discomfort. He described it as burning. He's had pedal edema for the last couple of weeks. In the last 2 nights, he's had some PND and orthopnea, so he's getting short of breath when he lays down and waking up in the middle of the night. So he's had some increasing chest pain and shortness of breath today, drives himself to the emergency department. And he says he's on no meds because he's healthy. So we already know that he's got some history here, but not being addressed, right? So what are Mr. R's risk factors? Do you want to call some out? Did you bring? Yeah, ex-smoker. Diet, yeah, poor diet. Anything else? Hypertension, yeah, that's not treated. Age, yeah, good one. Sedentary, yeah, not moving too much. And and I think there's hypertension, ex-smoker, sedentary, dyslipidemia, not treated. Stress, maybe. Poor diet, age, and male. He's over 50 years old, right? So he's increased risk for coronary artery disease. Good job, though. So the investigations we're going to do, so of course, he comes into eMERGE, he gets a history and physical. What's important about the history? You're looking for triggers, right? You want to see if there's any other reasons, what's going on here. So his heart rate's a bit elevated, 102, but regular. His blood pressure's a bit high, 160/70. His respirations are 30. So we do an ECG, do a chest x-ray, we do some labs, so kind of your normal sort of stuff. We do a troponin, TSH, looking for thyroid, make sure he's not hyperthyroid. May or may not do lipids, glucose, BNP, and maybe an echo. Oh, so I don't know if you guys can see this. If any of the nurses can. Can you guys see this from the back? See what's going on, CCU nurses? Can you see it? So he's got some inverted T's, he's got some elevated STs, some, yeah, kind of biphasic almost. So what's going on here? Huh? Yeah. So he's got a kind of a septal anterior happening here. This is his chest x-ray. So how does this look? Pretty hazy, right? So he's got a big heart. Yeah, it's at least 2/3 of the space here. Lots of hilar, and lots of curly B's. So he's got lots of fluid in there as well. So, and who knows about BNP? I know do you guys normally do BNPs in CCU? Only if it's ordered, eh? Okay, so I know when they come to our outpatient clinic, well, I know Naomi's always looking for the BNPs, right? We can get her to tell you about the guided study. So BNP is actually a peptide that's released from cardiac myocytes. It's basically due to wall stress released. So when someone's having heart failure or distended ventricle, then it's released. So your BNP is, again, kind of like a compensatory thing. It helps to, keep doing this. It helps with diuresis. It inhibits that RAS, the renin-angiotensin-aldosterone system, inhibits your CNS, so you don't want that high blood pressure and constriction, and it helps with vasodilation. So it's actually a good thing. But it gives us a good idea of, if this person is in heart failure. If it's high, then it's in heart failure. So these are kind of what we use right now. If BNP is under 100, then basically it's unlikely that it's heart failure. If it's over 500, then it's probably heart failure. If it's in between 100 and 500, it's basically kind of that gray zone where it may or may not be. And why is this helpful? Well, basically, sometimes patients come in, they're short of breath, and is it heart failure, or is it COPD? Is it pneumonia, or is it a combination of all of those? And sometimes we'll see, the medicine docs, they'll give, puffers for the asthma, antibiotics for the pneumonia, Lasix for the, potential heart failure. And usually they get better, right? That's the main thing. Usually they get better, but sometimes they're still not clear, is this truly heart failure, or is it lung disease or something else going on? So it can help. can be useful to rule out your heart failure when a patient presents with shortness of breath and the diagnosis is not clear. So Mr. R, so he's got this MI happening. He goes to the cath lab. He gets a drug-eluting stent to his left anterior descending. He goes to CCU. And so they do an echo at the bedside, and it shows that.
Can I just ask a quick question about BNP? Is there some there's benefit, right, when BNP is released? Is it doing something kind of beneficial for your system?
Well, I think it is like a compensatory sort of, enzyme. And I don't know if Naomi wants to talk to that at all. Basically, the higher it is, the more is being released and the more indication that it's actually heart failure. So as far as I know, it's kind of like a beneficial sort of thing. If they could, I don't know if they can
I don't think there's an acute beneficial thing.
It just kind of helps with diagnosis as a marker, like you said. Yeah.
It did something like
It does, but it does have it's trying to get the kidneys to diurese.
Yeah,
it's trying to get the vessels to vasodilate, but it's not. It has quite a short half-life.
Like
so
20 minutes.
In the long run,
Yeah.
it's not going to actually benefit the patient. But that is, it's a biomarker we use to measure.
If we could make it into a pill and give it that way or something, then it might. Yeah. Oh.
How expensive is the test?
Oh, it's fairly expensive. Is it like 30, 50 now? Okay, yeah. So I know for quite some time it was only like the CCU, the cardiologist could actually order it. But now I think medicine can actually order it. So if you work on medicine and you've got docs that aren't sure of the diagnosis of your patient, maybe just suggest that they send a BNP. And some of them don't realize that they can actually order it now. So I'm going to hand it over to Sarah now so that she can talk about echoes or ultrasounds.
Okay, I'm just going to do just a very brief overview of what a normal echo looks like, and then we will look at our patient's echo. You have to really see a normal first before you can get an eye for what an abnormal looks like. So this is just a very basic slide about echo. These are the things that we assess on every patient. Wall motion of the ventricles, both right and left, all four valves. The pulmonary pressures, which we can measure from the tricuspid regurgitation. The ejection fraction, filling pressures, that's all done by measuring the Doppler. And a whole variety of other things. But we're just going to stick with looking at images for left ventricular function at this particular time. So set up, oops, sorry. So she's scanning a patient here, and he is lying on his left side. So does anyone know why we scan the patients lying on their left side?
increased flow.
Gravity, it's all about gravity. When you're supine, your heart is predominantly under your sternum. Ultrasound can only go through tissue, it can't go through bone. So in order to try to shift the heart away from the sternum, we turn the patient on the left side, gravity makes your heart drop down a good inch or so away from your sternum, and we're able to see it much better in most people. So in some of the acute patients that can't turn, like ICU, sometimes CCU, we do them as is, where is often a slightly more suboptimal image than as if they could turn on their left side. So that is why we do that. So assessment of the actual function of the ventricle, there's 4 standard views that we do to look at it. So these 2 are from just next to the sternum, that's called the parasternal windows. This is the long axis of the heart, short axis. These 2 things are the papillary muscles. So this is this picture sliced right through here. So seen in cross section. So in echo, you try to get views that are orthogonal to each other. So we have the full length of the heart here. It's as if you're slicing the patient down the middle and looking in from the left side. That's how we get this view. This one is if you've sliced right through the heart and you're looking up from the feet. So a cross section. And then for these two, we've moved the transducer down to the apex of the heart, and we're looking up into the heart. Standard echo views, it's the heart inverted, right? The apex is at the top of the picture. So you just have to accept that. That's actually an upside down image of the heart. Why is it like that? Because the transducer is placed on the apex, and the sound beam comes up in a little fan shape. But all the images are displayed with the fan in the same direction, and so these become inverted. Once you just accept that, that's fine. In pediatrics, they actually view it inverted to this in anatomic position. Why they do that, nobody knows. But. So what does it actually look like? So this is a normal patient. This patient is 25 years old. This is our parasternal long axis view. So the structures that we're looking at here are the patient's head is up here. There is their aortic valve and their aorta, left atrium, mitral valve, left ventricle. So the blood flow comes through the pulmonary veins into here, through the mitral valve into here, does a 180 and up out the aortic valve. So what we're looking for with our eye when we stare at this is what is the motion of this heart muscle. So all the black interior of the heart is the blood. Ultrasound shows any fluid as black and all other layers of tissue as shades of gray depending on the fluid density within the tissue. So the pericardium is very white because that's dense fibrous tissue, but the actual myocardium shows as gray, right? So we're staring at this myocardium, and in systole, it thickens and it contracts, just like any other muscle, right? You do your biceps, and it contracts, it thickens. So we're watching for the heart muscle to be thickening. And in this young patient, that's contracting perfectly normally. So now I'm rotating the transducer 90 degrees, and there's a short axis in a normal patient. We're looking at the muscle all the way around here. Is it contracting evenly? Are there any areas that aren't contracting normally? Those are the post-MI patients. You get sections that no longer contract normally. And we'll look at one of those a little bit later. We can see the two papillary muscles there. So this is very normal. And you'll notice on echo reports, there's often just near the top, it'll say normal EF, 65% plus or minus 10%. That's based on these routine 2D measurements that we do on every patient. These are done in a very specific location on everyone, just past the tips of the mitral leaflets. So it shows you the thickness of the septum, the diameter of the ventricle in diastole, the thickness of the posterior wall. So this is how we get all the information about, does the patient have hypertrophy? What is the size of the ventricle? Is the ventricle enlarged? And then when we just scroll, like you can see here, we're at end diastole. Right here is our marker taking this image. And then we just scroll into end systole of the same beat. And then we just do the same thing again, measure the diameter, and the machine does a calculation of an EF. So this is what we kind of call the quick and dirty EF. If all of the walls of the heart are contracting evenly, this is a pretty accurate EF. If they're contracting evenly in a normal manner or evenly in an abnormal manner, it doesn't matter. This will be a fairly accurate EF. So here on this normal patient, we got roughly 68%. So that's where you see it right up here. That's always based on the 2D measurements. And so now I've moved the probe down to the apex of the heart, all 4 chambers. We're only interested in this case in the left ventricle. Is the shape of a bullet in a normal patient. So left side of the heart here, it's pulmonary veins, mitral valve, left ventricle, right, and right atrium there. And this is how we measure a Simpson's EF. So whenever we're trying to get a more accurate or specific ejection fraction, the 2D measurement is not good enough. This is more accurate because you're actually tracing out the volume. So this is the formula that we use, end diastolic volume minus end systolic over end diastolic, and you turn it into a fraction. So on our normal patient, at end diastole, we've traced the volume. It's up here, 102 mils. Then we go into systole, and I've put in, there it is, it's 36 mils. We do the math, comes out to 65%. So that correlated extremely well with his 2D measurements, and there's no reason why it shouldn't. And so after the 4-chamber, then the orthogonal view to that, 90 degrees, is the apical 2-chamber. And so you will see on reports when it says biplane Simpsons, that's now incorporating a 4-chamber EF, a 2-chamber EF, and taking the average of those two, and that is called the biplane Simpsons, okay? So that's our normal person. Okay, what'd I do? Okay, yeah, there's our normal guy. And in echo, everything we use is based on the American Society of Echo. That's the gold standard in North America for all of our measurements. And this is the rating scale that we use for all the echo reporting. And they've just recently incorporated the gender into this as of January 2015. And now this is our patient that we were talking about, Mr. R. So Mr. R's heart is no longer the shape of a bullet. It's really round. It's contracting, but it's contracting extremely poorly globally. So we got a great big dilated heart, poorly contracting. So they've done the 2D measurements up here, and you see severe dysfunction. And then down in the report, they did a biplane Simpsons EF 20%. So just let it kick up here while it gets going. So you can, so it's a little easier to see when you can compare the two. So normal, nice and snappy, coming in really well. And then the severe systolic dysfunction, very poor. To the naked eye, that's pretty obvious. But you got to realize there's a huge grade in between these two, between a 65% and a 20%. And that's where just the experience comes in. It takes about probably a full-time year of looking at these before you get a trained eye to kind of be able to eyeball an EF. And in the short axis, so normal here, dilated, contracting evenly but very poorly all the way around. And from the 4 chambers, same thing. So other things that are noticeable now here, look how big the left atrium has become all dilated as well. This is fairly typical when you have very poor systolic function. And the 2-chamber, same thing. So the 2D measurements on this patient. So his left ventricle, do you remember in the last patient, I believe it was 48 millimeters in diameter. This guy's is 92. So it's huge, it's a beach ball. And then his systolic measurement, and we're getting a 2D EF of 27%. But our protocol is that for everyone with an abnormal EF, we have to do a Simpsons. So when we did a Simpsons on this guy and put the numbers in, so there's his volume was 377. In a normal patient, it was 102. So huge, huge heart here. Minus systolic over diastolic, so the EF was 20%. And the other patients that we just need to think about, where the wall motion is not necessarily globally reduced, it's regionally reduced, and these are the post-MI patients. So in echo, we use this map. These are our echo views that I already showed you, the 4-chamber, but with a coronary perfusion pattern in them. So when we see dysfunction, we use this to tell which coronary is involved. And so these are all of our CCU patients. So just a brief look at what this actually looks like. Okay, so You might just glance at this and think, well, that's not too bad. If I was measuring right across here from the 2D measurements, this wall's coming in, this wall's coming in. If you measured 2D measurements there, it might not come out so bad. But then you got to look further up. What's happening up here? Absolutely nothing. So there's a hinge point right there. So this is the LAD, this is the MI up in this region. So in patients where there's a regional abnormality, the 2D measurements are rubbish. You can't use them because they're not incorporating this area of dysfunction. So these patients absolutely need the biplane Simpsons. So on the 4-chamber view of an MI patient, same thing. So this part of the ventricle, you can see it's thickening, it's contracting, but right there, there's the problem. It's thin, it's moving just because the whole heart's moving, but it's not thickening. So this is damage from an MI. So in order to get the ejection fraction from this, we need to trace the entire volume in 2 planes and get a biplane Simpsons. Any questions about any of that? Okay, who's next?
Okay, so this part of the presentation, I'm going to briefly go over the medications that you frequently see in treating heart failure patients. I'll be highlighting the important points for each class of medication. I won't have time to go over all the details, but if you have any questions at the end, feel free to come up and ask. So this is a list of medications that you will often see in treating heart failure. Beta blockers, ACE inhibitors, ARBs, aldosterone antagonists, vasodilators. This group all show mortality benefit in the studies that have been done for heart failure patients. Digoxin and diuretics are normally used for more symptomatic management or last resort. And this is a pretty busy slide. We won't go through all the details, but it's basically to kind of illustrate the algorithm that we would use for treating heart failure patients. Our first lines are usually the ACE inhibitors and beta blockers, and titrating them to target doses. And usually when patients are more clinically stable, we will add on spironolactone and use diuretics for symptom management. So going into beta blockers, this class of medication are used to slow down the heart rate and therefore allow the ventricles to fill more effectively and pump out your ejection fraction a little bit better. It also lowers the heart workload. The studies have shown that it can decrease hospitalization and decrease mortality in all patients, so class 1 to 4 heart failure, so mild heart failure to severe heart failure. The dosing, we normally have to start low and go slow and titrate up slowly over a couple of weeks. Patients will often experience worsening of heart failure symptoms due to some of the side effects of this medication, like shortness of breath and fatigue, but these side effects usually go away after a week or two as patients build tolerance to these medications. And other things to watch out for with this class of medication is the hypoglycemic risk. So for diabetics, we might need to be monitoring glucose a little bit more closely. Worsening of heart failure or erectile dysfunction is also another one that a lot of patients may note as a reason why they want to discontinue. One thing to note for these medications, it's important to not discontinue abruptly, and discontinuation needs to be tapered down slowly as well, especially with patients with concurrent angina. And here I'm just bringing up Diane's earlier slide that illustrates the RAS system, or renin-angiotensin-aldosterone system. Here I can illustrate where the ACE inhibitor and ARBs, as well as the aldosterone antagonists, work in the whole cascade. So the ACE inhibitors will inhibit the angiotensin-converting enzyme here, which blocks the system from here on out. Angiotensin receptor 2 blockers, or ARBs, will block this enzyme, or this receptor itself, and again block down the cascade from here. And aldosterone antagonists will prevent a reduced aldosterone secretion. Oh, okay, there we go. ACE inhibitors, just to go into a little more detail. So those are the prils, the captopril, enalapril, ramipril, etc. This is another class of medication that has shown reduction in hospitalizations and mortality, as well as reduce in reinfarctions in patients with MI. Again, we want to start low and target and go up to target doses slowly. All of these heart failure medications have target doses that we want to try and reach, and these target doses come from the trials that have shown benefits in the mortality and hospitalizations. Some things to watch out for with the ACE inhibitors is we need to monitor your renal function quite closely and look for any electrolyte disturbances. One common one is hyperkalemia, so increasing potassium, hypotension, angioedema, and one side effect that some patients may experience is actually a dry cough. And for patients who do experience a dry cough, we would often switch them to the ARBs, okay? And this class of medication works similarly as the ACE, as you can see with the cascade there. It works at a similar step, and also has shown reduction in morbidity, mortality, and often patients who have that dry cough with the ACE, when they switch to the ARB, it goes away. So some things to watch out for with the ARBs is, again, we want to monitor their renal function and watch out for hyperkalemia, and then also monitor for blood pressure as well. So you may wonder, like, what if their blood pressure drops quite low? Do we still want to keep going with that target dose? Do you still want to keep increasing your blood pressure medications? It seems kind of like counterintuitive, but we actually do want to try our best to reach target doses with these patients as much as they can tolerate. So even if blood pressure is down to 90 systolic, or if heart rate is down to 50, if they're asymptomatic, if they're not having falls or having syncopal episodes, then we want to try and keep them on that dose. But if, of course, if they're very symptomatic, they're feeling dizzy, very, very fatigued, and at risk of falls, then we would hold back and just try and target the highest dose that they can tolerate. Okay. So going on a little bit more about the aldosterone antagonists, these are spironolactone, this one's the most commonly used, and also eplerenone, which is a substitute. This class of medications is normally started on patients who are clinically stable and are on ACE inhibitors and beta blockers already. And one limitation for using spironolactone is, one of the side effects is gynecomastia, which is breast tenderness, enlargement. And with those patients, we can offer eplerenone as a substitute. This medication, eplerenone, is not covered, and it can be quite expensive, but with special authority, it can be covered partially as well. So again, with these medications, we want to watch out for hyperkalemia, hypotension, and irregular menses is another side effect. Okay, so going on to vasodilators, these are the nitrates and hydralazine combination, and they have been shown to reduce mortality as well. And it's often used as a substitute for patients who have reduced renal function and can't take an ARB or ACE inhibitor. Again, you titrate to the target doses as tolerated, watching out for blood pressure, and here are some of the other side effects listed up here. GI upset. The nitrates sometimes may cause headache and hypotension as well. With the isosorbide dinitrates, sometimes it may be substituted with nitroglycerin patch. It's a little bit more long-acting, and people will usually experience less of the side effects. Okay, so going on to digoxin. This class of medication has shown to have some morbidity benefit in mild to moderate heart failure class patients. It's usually used as a last resort for patients with symptomatic heart failure who haven't found as much improvement with the other medications. We will try digoxin. And the dose, again, is dose based on your renal function, your age, and also whether you tolerate the side effects as well. So things to watch out for: confusion, color, dizziness, color changes, nausea, vomiting, so a lot of GI effects, diarrhea, AV conduction, and SVT. Normally, you may hear about getting digoxin levels. We don't normally get digoxin levels regularly to see if it's therapeutic. We actually only look for digoxin levels if we suspect toxicity or if their renal function declines, and we want to make sure that it's not at a toxic level. So diuretics is the final class of medications I'll talk about for heart failure. And of course, Lasix is one that we see quite often. And this medication is titrated as needed. Common doses would go from 40 to 60 milligrams a day, but we do see patients with as high of doses 120 milligrams twice a day. So it's really individualized and depends on the patient themselves and how much diuresis they need. Sometimes patients will need an addition of a second diuretic agent, so hydrochlorothiazide may be used for synergistic effects. And also metolazone may be added for patients that are more resistant to Lasix. And this medication is usually given half an hour before the Lasix, and it helps the effect of Lasix take place a little bit better. And then also formulation. There is a difference in potency between IV and PO diuretics. IV is much more potent. It's actually almost twice as much potent as a PO. So usually we give IV route for patients who are more severe, more symptomatic, and usually in hospital where it can be administered. Okay, so just to go over some medications to avoid in heart failure patients. These medications can worsen patients' heart failure. NSAIDs, pioglitazones, even licorice-containing products and corticosteroids should be avoided. They can cause sodium and fluid retention, which we do not want in this patient population. Non-dihydropyridine calcium channel blockers. So those examples are diltiazem and verapamil. It's not the amlodipine, not felodipine. That's a different class of calcium channel blockers. This class of calcium channel blockers are negative inotropes, which means they can reduce muscular contractility, and which we do not want as well for patients who already have some reduction in their cardiovascular muscle contractility. And also the pseudoephedrine, this kind of medication can cause tachycardia and hypertension, and also something that we want to avoid with these patients. Okay. Yes, Pam.
Licorice-containing products, why?
Sorry? Licorice-containing products? Oh. Oh, yeah, they actually have a lot of salt content. Yeah, so we want to avoid, well, so anything with like salt content we want to avoid, but that's something that not a lot of people will think about or consider. Yeah. Yeah. Any other questions before I pass it back to Erin? Sorry? Oh, to Diane, sorry.
So what are some of the triggers? You know, you all see heart failure patients. Doesn't matter where you work, whether you're in community, on medicine, surgery, CCU, ICU, you're always going to be coming across heart failure patients, whether it's a history of heart failure or an acute exacerbation or chronic heart failure. So it's really important to look at triggers. You know, why has this person had an exacerbation of their heart failure, especially if they've ended up in hospital or had a worsening. So there's some that are cardiac related. So certainly something like a rapid AFib or a rapid A-flutter can tip someone into heart failure. Things like sinus tachycardia can also exacerbate your heart failure. Certainly, like we said before, that ischemic events or infarctions, whether it's a chronic ischemia or angina or an acute MI event can lead to heart failure. Your uncontrolled hypertension or high blood pressure can certainly cause your high heart failure. And certainly, you know, either suboptimal pharmacological regimes for your heart failure, whether they haven't been titrated, you know, up on their beta blockers and their ACE inhibitors or ARBs, and maybe their diuretics have been changed by their GP, and then, you know, they're not holding on that lower dose of diuretics, so they go into failure. There's a number of other non-cardiac causes of, or triggers of heart failure. So certainly we see a lot of these like infections, even simple UTIs or pneumonias, right? Just that increased demand on your myocardium, increased oxygen demand, it can tip people into active heart failure. Certainly things like anemia, decreased hemoglobin, stresses the heart. Medication interactions that Bonnie's just talked about, and then self-care difficulties. So we'll talk about self-care management of heart failure, and oftentimes people, they need to be educated on how to manage this. We deal a lot with people with coronary artery disease, and again, because it's the leading cause of heart failure, it's really important that we teach people to address their and decrease their risk reduction or decrease the risks of coronary artery disease. So all of us as nurses, we're really key, whether it's family members with potential risk factors or our clients, we want to be slowing that progression of heart failure and coronary artery disease. So, if they have hyperlipidemia, make sure it's treated and monitored, make sure that people are on a low-fat diet. It's important that we all maintain an ideal body weight. It's important for all of us to be physically active, but especially heart patients, remaining a non-smoker, managing stress, and certainly managing hypertension. So these are some of the heart failure self-management skills. So again, it doesn't matter where you work, whether it's community, whether it's in hospital, medicine, surgery, ICU, CCU, you're going to be coming across these heart failure patients. So it's really important, and one thing Erin and I have always noticed too, that a lot of patients, they may have had 1, 2, 3 admissions, for heart failure, regardless of the cause, and they come to see us in clinic, or we go to do some education with them, and they're not even aware that they have heart failure. Oh yeah, I had water in my lungs, or I had pneumonia, or I had a heart attack, but they're not even aware that they have heart failure. So it's really important, and whether the physicians are telling them and it's just kind of going over their heads, or whether they're just not being told. So, feel free. Talk to them what they know about their heart and their heart failure. It's important for patients to know what their heart failure symptoms are. It's important that they recognize them and report them early, because certainly the sooner that they can report these, then the sooner that we can start treating it. Oftentimes people might notice that their ankles are getting swollen, they're getting more winded, they're getting a bit more bloated in their belly, but they're just not paying attention, or they think, oh, I've just eaten too much cake this week or something, right? So it's important to teach people to weigh themselves at home, I know Erin and I try to do a lot of education, but it's also really important, whoever is at the bedside, if you can be trying to teach people. I know everyone's really busy, but sometimes just taking a minute to explain, why we're getting you on the weight scale. I know in CCU you have the bed scales, right? So patients probably don't even know they're getting weighed, but it's really important, just take a couple of minutes, say, we're weighing you because we're giving you diuretics to make you pee, to get rid of that fluid buildup, and look, you've lost 3 pounds overnight. We teach people to report a 4-pound or 2-kilogram increase in weight in 2 days, or 5 pounds or 2.5 kilograms increase in a week, because that's most likely, a rapid increase like that is usually fluid buildup or fluid retention. And if they report it, then usually their diuretics can be adjusted or increased for a couple of days. It's really important for them to maintain a fluid limit. Usually we say 1.5 to 2 liters per day, because less that goes in, less workload of the heart, less potential for fluid buildup. Less in also means less diuretics are needed to get that extra fluid out. And often patients are saying, well, we're always told that we should be drinking at least 8 cups of water a day. And that's fine if your heart and kidneys are functioning normally. But in someone with a big, soggy, boggy heart, that extra fluid, it's not getting pushed forward through the system, and it's just kind of third spacing it in and up in lungs. Sodium limits, 2,000 milligrams a day, which is equal to about 3/4 of a teaspoon in everything you eat. So again, there's lots of education we can do about that, teaching people how to read labels and avoiding the 3 Ps, processed, packaged, and pickled foods, trying to stay with fresh food. So there's lots of information out there now on how to manage heart failure, and it's a real process for patients. It's so overwhelming, so much information. So any, a couple of minutes here, a couple of minutes there, at the bedside, just reviewing with patients, why we're recommending these things and kind of getting them on board with these things before they even go home. Give them something that they can track their fluid balance in hospital and track their weights even, and just explaining, some of the signs and symptoms and relating it to the patient, right? If they have shortness of breath or orthopnea or swollen ankles, then, they'll probably get it again if they're going to be retaining fluid. So I'm going to hand it over now to Erin so she can do the second case. This one won't be as long as
Mrs. P has HFpEF. Someone says she looks like Joan Rivers, but this one looks a little bit older to me. So her history, she's a 70-year-old female, history of diabetes, high blood pressure, a little bit of asthma. She has some coronary artery disease, but not enough to actually put a stent in there to try to unblock, but no history of MI. So kind of typical old lady, elderly lady that we see. This is actually her third admission to the hospital now. So she's had 2 previous admissions in the last 2 months, both with pneumonia. This time, she's having kind of symptoms that look like heart failure to you guys. She has shortness of breath, orthopnea. If you guys remember, orthopnea means when you lie down that you have you can't catch your breath. P&D, so you wake up in the middle of the night trying to gasping for your breath. And she also has a little bit of confusion too on top of this. What kind of meds is she on? She's on some Coversil or Perindopril, aspirin, a little bit of metformin, atorvastatin, some Ventolin, Symbicort, and probably 8 vitamins. We do a clinical examination of her. She looks pretty pale. Resp rates are 32 rests per minute. Heart rate's a little bit on the faster side, 100 beats per minute. Her blood pressure is 179/75. And she goes, oh, that's good. It's a lot higher normally. Have a listen to her heart. And we can actually hear an S4 there. So if we all learned this in school, and honestly, I have trouble hearing an S4 a lot of times, but it would be Tennessee, Tennessee, okay? That's the 4th heart sound I usually would hear. Lung sound, she sounds diminished, but it actually doesn't sound too bad. It's kind of clear. She is visibly short of breath. She could barely talk as you're getting her history. JVP is elevated, and we wish we actually had more time to go through that with you guys, but that'll be part 2. So her neck veins are quite elevated. She has pitting leg edema up to her knees, okay? To the point that she's not even wearing her shoes. She's wearing flip-flops. She's pretty fatigued. She can only walk a block. Normally she can walk at least 2 blocks, down to her grocery store. And she hasn't been sleeping the last 2 nights because she just can't lie down without trying to catch her breath. She has a poor appetite, and her belly is pretty distended. Looks really bloated. Okay. So what do you guys think her NYHA class is?
3D.
3B.
Okay, 4.
So we're classing her as class 4, okay? Symptoms at rest. Unable to do any physical activity without discomfort. What kind of investigations are we going to do for Mrs. P? So very similar to the first case. We're going to do a thorough history, ask about triggers, which I'll go into a little bit more, and Diane had reviewed about cardiac and non-cardiac triggers. Do the physical, which we just did. Her ECG actually doesn't look too bad, just a little bit fast, 100 beats per minute, but it's regular, it's sinus rhythm. No ST changes or anything. Chest X-ray looks all right. There is a bit of fluid there, but not, she's not totally overloaded. We do labs, CBC lights, BUN, creatinine, troponin, TSH, lipids. Those all look good. And of course, now we're going to say, hey, doctor, maybe we should add a BNP to this. We don't really know. Maybe it's for pneumonia. Maybe it's heart failure. And we're also going to do an echo. So,
All right, this one will be a lot shorter here. So, so this lady has an echo, and right up top here, normal EF, 65% plus or minus 10%. Normal right ventricular function. Elevated filling pressures and severe diastolic dysfunction. So what does this look like? So there is our normal person from before, and here's our patient with severe diastolic dysfunction. Is the ventricle contracting well? Yep. Valves for her age, they look pretty good. That's just a little bit thick and crunchy, but you know, for a 78-year-old, that looks pretty okay. So just looking at that, that looks normal. In the short axis, once again, for severe diastolic dysfunction, that's a pretty snappy-looking ventricle. And from the four-chamber, our normal patient, our severe diastolic dysfunction. So the whole point here is you can't see diastolic dysfunction. It's not something you can visually see on an echo. So it's a diagnosis that's derived from a number of secondary things that we measure. One of the big things you notice in here is she's got an enlarged left atrium, and that will be contributing to the high filling pressures, right? Pressures in here are now going up. So how do we diagnose it? We have to use an algorithm based on a number of things, specifically the Dopplers that we measure. So this is the grading from normal down to severe diastolic. This is the category that our patient falls in. So we look at the mitral inflow Dopplers. We can try to provoke changes with a Valsalva maneuver. We look at the tissue Doppler, and we look at the pulmonary venous flow Doppler. And just a little glimpse of what some of this will look like. So in our normal 25-year-old, this is the mitral valve inflow. So this is early diastole, the mitral valve opens, you get a nice whoosh of blood going in. At an end diastole, you get atrial systole, a little kick, and another nice whoosh of blood goes in. These velocities are all normal. In our patients, this is high filling pressure. So the mitral valve opens and the velocity here is high. This is the velocity here, centimeters per second. So the blood rushes in because it's high filling pressures. And yet at the end, atrial systole, the atrium kicks, but hardly anything can go forward because it's meeting resistance. And what it's meeting resistance from is a stiff ventricle or something in the afterload that's preventing the ventricle from accepting the blood. So this is all pointing towards diastolic dysfunction. This is what we call tissue Doppler. So what we're doing is sampling the muscle right here at the mitral annulus. And in a normal patient, this muscle is very flexible and moves up and down very easily. So in our patient in systole, in it goes, and diastole, very bouncy, very pliable. In our patient, all of this now is damped down and reduced because it's becoming very stiff in the longitudinal dimension. Even though in cross-section it was contracting well circumferentially, the long fibers of the heart act differently and they're becoming much more stiffened up. You can't see that with the naked eye, but you can see it when you test it with the tissue Doppler. So when all of her parameters were put on that chart, this is what the cardiologists do. They look at all these things, look at the chart, and they give it a grade. And in her case, she's come out to severe diastolic dysfunction. Okay. Oh, the other thing I was just going to mention is you'll see on many echo reports, let's say indeterminate diastolic dysfunction. These are cases, usually AF. AF will make all of those, like the mitral inflow, all varying different levels. Then you can no longer measure it accurately. Anyone with valvular stenosis or significant valvular regurgitation, again, those Dopplers will not be accurate for measuring diastolic function, so they have to kind of throw them out and call it indeterminate.
Sarah. Yes. So, why does Mrs. P have heart failure or preserved heart failure? And to be honest, I didn't know till last year that anyone with a systolic function of 65% could still be in heart failure. Up until that time, I thought, oh, yeah, their echo looks fine. They don't have heart failure. It must be something else. It must be their COPD or something. But studies have shown now, and they have proved it, that yes, these patients do actually have diagnosis of heart failure. And if you remember, Mrs. P has history of long-standing diabetes, long-standing hypertension, and those are the comorbidities that have led to her ventricle getting very stiff, unable to relax to allow blood to fill and improve cardiac output. So as you can see here, normal heart, the ventricle, the size here, versus a thickened myocardium in Mrs. P. You can also sometimes see that on the ECG with LVH. This is just another picture here also to show how, if you just took out a piece of the heart, a normal heart, you could see the muscle wall there where it's very thickened in a hypertensive heart. And I actually have a heart you can pass around that you can see how the heart actually feels when it has hypertension. You just have to turn it on. What I like in usually use that analogy when I think about it is that those with preserved heart failure, I don't know if you guys know what a bellows is, but it's like an old-fashioned fan that you use to try to get a fireplace going a lot more. And if you just think about trying to get air into that bellows, you have to stretch it out, okay? And I think of it as the heart trying to stretch out, and it's so stiff, it just won't relax, and it won't allow air, just like a heart will not allow the blood in to be pushed out. Heart failure with preserved ejection fraction etiology. So the #1 cause or comorbidity for this is high blood pressure, which Mrs. P has, okay? Diabetes, followed by coronary artery disease, valvular disease, okay? Anything that actually affects the diastolic filling of the heart. Hypertrophic cardiomyopathy, okay? That affects the wall of the ventricle and causes it to be stiff. Infiltrative cardiomyopathy. So those are your sarcoids, amyloids that affect the tissue of the heart and make it stiff. RV dysfunction, and then high output heart failure. So that's not as common, but an example would be like someone who has thyroid storm and the body wants to have a high cardiac output, and the heart has to try to meet that, so it's constantly trying to push, push, push and pump blood through. And then the muscle gets stiff, it gets thick. I like this slide comparing heart failure, those with preserved ejection fraction and those with systolic dysfunction or reduced ejection fraction. So those with preserved ejection fraction, the average age is definitely a lot older. They tend to be more likely female, have a history of high blood pressure, have a history of diabetes. BMIs, not too different. Interestingly enough, also have a history of atrial fibrillation, up to double compared to those with low ejection fractions. So going back to Mrs. P and thinking about triggers. So why did she end up in hospital again? Can you remember the case where she had, a history of pneumonia? She had been in hospital twice before. She had really high blood pressure coming in, multitude of cardiac reasons that could have caused her to come into hospital. The high blood pressure. She decided, oh, I'm on all these antibiotics. I'm going to just stop taking some of my other pills right now to balance it out. And so she stopped taking maybe her high blood pressure pills for a while there. She has the history of pneumonia, so maybe the infection was a potential trigger. She wasn't feeling good, so she, wasn't able to prepare for foods freshly. So she decided, I'm going to have some Campbell's soup, and was having that consistently, causing her to go into fluid overload. So there's a lot of triggers. And, why do we keep talking about triggers? Diane and I, when we go see patients in hospital, we're always looking for, why did they come into the hospital with heart failure this time? Because that really tells us how to cater the education to them. The doctors, they're great. They go in, they say, okay, we're gonna diurese them, we're gonna start them on this medication, get them in, get them out. But a lot of the times the focus needs to be on figuring out what got them into the hospital this time, because we know 75% of these patients have a diagnosis of heart failure already. So what are they doing that is putting them back in the hospital again, over and over again? You can ask this Bonnie. Bonnie's going to go over management of heart failure.
Okay, so I'll just quickly go over what we do for patients with preserved ejection fraction. And it'll be a lot shorter than the reduced ejection fraction because basically there's a lot less evidence for management in patients with preserved ejection fraction heart failure. Mainly there isn't really evidence that shows reduction in mortality or morbidity or reduction in hospitalizations, except for one study. It's the TOPCAT study, and that one looks at spironolactone studied in a pretty big population, 3,000 patients across the world, or in different parts of the world. And the overall study actually didn't show a significant reduction in any of the primary endpoints. But when they did a post-hoc analysis and they extrapolated from the patient population from the Americas, there did show a significant reduction in cardiovascular mortality and reduction in heart failure-related hospitalizations. So that's so the spironolactone is one medication that we would go to for patients with preserved ejection fraction. And then so in this list of medications, aldosterone antagonists really are the only one that have evidence behind it for patients with HFpEF. And the other medications you do still see in this patient population because we want to, again, address the other comorbidities like high blood pressure. If they have atrial fibrillation, we want to make sure they're rate controlled. So you will see some of these other medications as well. And then diuretics is still quite important in this patient population because we want to, again, manage their symptoms. So if they're quite fluid overloaded, we'll definitely need to give them diuresis. Okay, so just to kind of summarize that short bit, we want to, keep heart rate slow, blood pressure low. For this particular patient, Mrs. P, blood pressure control is a big thing, so make sure she stays on her blood pressure medications and is optimized that way. We want to diurese her so she's not so short of breath. Control her other comorbidities, so her diabetes, we want to make sure that's well controlled and that's not causing worsening of her heart failure. And then self-care management for when she goes home. And I'll quickly pass this back to Erin, and she'll go over some self-management tips.
So you guys have already seen this slide, and we hope we've driven it home that we really stress the heart failure management, and you guys are on the front line to do this. I know it's difficult on the ward to get this information across to patients when you have so many tasks and so many other pressing issues, but this is really important to prevent them to come back into hospital. If you are weighing your patient, you should be going, oh, your weight is this today, Mrs. P. You should write that down. The day you leave, write down your weight, because if you go up 4 pounds this week, you should be calling your family doctor. It's very fast, it's very simple. But this is when you guys call us to come over to the hospital, that's what we're doing, that's what we're telling them. Other things, so symptoms. So not every patient actually has the same symptoms of heart failure. Some people it's shortness of breath. Some patients it's their legs. They notice that they swell up. So it's important for them to know what their heart failure symptoms are. And what does that mean, right? Just like Diane said that, patient goes, oh, I had fluid on my lungs, now I don't, I'm better, I can go and eat my chips. And literally, we get that all the time, okay? Fluid limits, I won't flog that, but definitely when they're in the hospital, we see them all the time with their big canister of water, and they're sipping that away at that, and we ask them, do you know how much is in that cup? Do you know that you're on a limit? And that starts in the hospital, okay? We really want to reinforce that. And sodium limit. of course, it's interesting how we can control all that while they're in the hospital, and as soon as they leave and go back into their own environment, they're back eating their Kraft Dinner and, you know, Campbell soups. We often hand this out. This is available on the BC Heart Failure Network, and if you would like some copies, we can provide some for you. But this is actually on a website, and this one's I must say it's a little busy, but I hone in right on the top aspect here. I say, these are the 6 things that you do every day, and if you do these, you're staying in the green. If you don't, you start going into the yellow, and by the time you're red, you're coming back to emergency. And I tell them to put this on their fridge, and it really does help patients. Take-home message. So there's a lot of them, actually. When caring for someone with heart failure, think about why do they have heart failure, okay? Is it that they had an MI? Is it that they had a whole weekend of Chinese food, or maybe just one day of Chinese food? Do they have, what kind of heart failure do they have? Reduced ejection fraction, preserved ejection fraction? Why did their heart failure get worse? Okay, lots of these patients, again, are living with heart failure. What got them into the hospital? And it could be simple as their caregiver went away, or they were in the hospital, and then they weren't able to manage themselves at home. Pharmacological management, we keep saying start low and go slow, okay, just to help prevent potential side effects. I find it amazing how cancer patients accept, you know, getting chemo, losing their hair, getting nausea and vomiting, going through surgery, and yet, you know, if you tell a patient who has a heart failure, you might get a little bit dizzy for about a week or 2, but bear with it. It shouldn't last the whole time. This is to help make your heart muscle stronger. I tell patients all the time, you have equivalent to diabetes. Dr. Barani says, you have cancer. This is cancer of your heart. And that kind of scares them, but it also gets them going that, you know, this is something that doesn't go away, you live with it. Heart failure education is key. Would love it if everyone can start right from the get-go. Patients experience many difficulties despite their deliberate attempts to actually make healthy choices. So, you know, just an example of a patient who knows they're on water pills, but then somebody else says, oh, well, I know you're supposed to drink 8 glasses of water. So that's what they do. They're trying to be healthy, and they drink 8 glasses of water. And especially since I'm on water pills, that makes sense. I should be drinking more. Or we tell them your limit is 1.5 liters, so they drink at least 1.5 liters of fluid a day. It's amazing how it gets misinterpreted. Lastly, we want to make sure that you help patients understand why they have heart failure. So why do I have it? How do I address it? Okay. And then who do I go to when I start to have symptoms? For patients part of our heart function clinic, they can call us. For those who don't, they need to know that, yeah, when their weight goes up, report it to a family member who can report it to the physician or doctor, their family doctor. Okay? So we have hopefully a little bit of time for questions. I know we went over a little bit, but I hope you're not as confused as this little kitty. And then these are just some resources that we have for you guys, and also for patients to go online to get some more information and handouts if you need it.
Does anybody have any questions for these guys?
Oh, yes. I just wanted to thank Suzanne from Survey. She provided the food tonight, so we didn't get hungry and everyone stayed awake for this. So thank you so much.
Are there any specific